with my, I'll share my screen and so can you all see it now?
Not yet.
Ma'am, please click on share screen on the below.
Go down. Share screen is there.
One second, I will just. Yes, yes, I've shared screen.
Select the slide.
Is it visible?
No,
Not yet.
ma'am.
Is it visible?
Madam, go to share screen, select your slide, and then don't go back to share screen again.
Ma'am, please send your slide to me. I'll just share on your behalf.
Okay, shall I email to you?
Yeah. Yes, ma'am. Oh, you can WhatsApp me, no problem.
So, dear viewers, continue watching, and we have some couple of minutes technical hitch, which always happens, and it is much better than in a conference where there is always a delay of 1 hour or 2 hours. We are sharp in time and will finish sharp in time. So, namaste everybody, Pushpa ji, Poonam ji, Dinesh ji. They all are people can ask their questions, and all your questions answers will be answered. So yes,
Sorry.
In the meantime, let's have a couple of minutes chats with you. Let me pick up the news and see what's new. And there are states who are coming out with guidelines for Unlock 1. Maharashtra extends lockdown till 30th of June. Then we have 200 special states starts operation from June 1, which is good. And India's recovery rate is 50%. Cyclonic storm may hit Maharashtra. Terrorist camp launch pad in POK. There's nothing more as far as COVID is concerned. Let me see what's new in COVID in the international era. In the international era, we have crossed 62 lakh people so far. India was supposed to be, it is still in the ninth, 183. So by morning, India will cross Germany number of cases and will become number 8 in the position. And maybe by morning, it may even cross France. So India is likely to cross Germany and France as far as number of cases is concerned. Maybe another 12 hours, USA, Brazil, Russia, Spain, UK, and Italy will be above India. And India is also likely to cross Italy, UK, and Spain because their number of cases are very, very, very low. And after a week, you will have USA, Brazil, Russia, and India on the top 5 situation as far as number of cases are concerned. And let's talk about India. As on today, we have confirmed 183,000 cases. And if the number of cases continue to rise like something like 7,000 to 8,000 per day, and then in the next 3 days, we will cross 200,000 cases in the country. The death rate in India is also 5,188 cases. Maharashtra leads with 65,000 cases. I'm sure with the way they are going with active number of cases, they will cross 100,000 cases. Maharashtra will cross 100,000 cases, and India will cross to 200,000 cases. 50% of cases may end up in Maharashtra. Even today, 40% of the cases are in Maharashtra. Are we ready? Yes. Kindly go
Yes.
ahead, madam.
Okay. So, as I said, that we will be talking about coagulopathy in COVID-19 times, which is largely we now today know is due to thromboembolism. So in my talk, can I go to the next slide, please? Can I move it from here? Okay. So I'm going to be discussing it into several heads. I'll start with the background, go on to pathogenetic mechanism of action of COVID, go on to the clinical course, and then talk about COVID-19 and changes in hemostasis, which lab tests are relevant that we need to do, causes and mechanisms of coagulopathy in COVID-19, and treatment guidelines as we have today. So in the next slide. So as we all know that this disease is caused by SARS coronavirus 2. And this was first started in December 2019 when multiple cases of pneumonia were seen in Wuhan. In January, the WHO declared it was caused by a new virus, which is coronavirus type 2, which is slightly different from the coronavirus 1 that we had in 2003. And now we know there is a global pandemic with more than 2 million cases confirmed. Can I have the next slide, please? So, COVID-19, the virus is SARS-CoV-2, and this virus, we know everyone is taking nasal and laryngeal swabs. Why is it? Because the virus goes into the body through the nasal and the laryngeal route, and it enters the lung through the respiratory tract. And this virus attaches to the alveolar cells by the ACE2 receptors, and then it enters the alveolar cell. So it enters all cells which have ACE2 receptors. Another common one is the endothelial cell, renal cell, GIT system endothelius. So the major problems it causes is in the respiratory system. And what it does is that it produces pneumonia by several mechanisms. One is that it triggers excessive immune reaction in the host. And the second is, in some cases, it can actually cause cytokine storm, which means a large number of cytokines are produced, and these lead to a lot of tissue damage, particularly by interleukin 6. And this leads to acute systemic inflammatory syndrome, which is characterized by fever and multiple organ dysfunction. It also can affect other systems, as I told you. In cardiovascular system, the most common site of affectation is damage to blood vessels, particularly in the microvessels, the small blood vessels, where it enters the endothelial cells while the ACE2 receptors and causes damage, leading to platelet activation and platelet aggregation, leading to increased thrombophilic preparation of background. Next, please. So if we look at the clinical course, the clinical phase is divided into three main phases. The first is the viremia phase, when there is virus in the body. And then there is an acute phase, which is where we also get pneumonia. And then depending on the immune status of the patient, if the patient is having a low immune status and has comorbid conditions, it leads to very inflammatory kind of disease, and recovery phase does not happen. On the other hand, if there is an effective immune system of the patient, then there is recovery phase which happens soon enough. Next, please. So if you look at the severity of the disease, you can have, you hear so many of carriers of this virus. So you can have patients who are asymptomatic, or those with mild infections, which is just like a flu symptom, having fever and some cough, or it can be severe when the patients initially present with single organ failure, typically respiratory insufficiency, However, it progresses very fast and requires hospitalization and oxygen support. And therefore, these are the kind of patients that we are very scared about. They can easily go into intensive care and they lead to multi-organ dysfunction. And in between is the moderate type of severity. Next, please. So there are three main pathogenetic mechanisms that we see in relation to COVID, which can lead to coagulopathy. The first is hypercoagulability. Now, let's see what is the cause of this hypercoagulability. So, as I told you, COVID-19 basically focuses on the lung and it causes edema and clear thrombus formation in the blood vessel, a white kind of edema fluid and a white kind of thrombus. And this has been demonstrated on autopsy findings. So we do know that unlike what was earlier believed, it is primarily a lung damage, it is primarily a kind of thrombus which is forming. And there is more evidence which points towards this direction. You have very high elevated D dimer levels seen in almost 50% of COVID-19 patients during disease progression, and almost 100% of those who die have been shown to have markedly elevated D dimers. In a study done in China, they found that D dimer in severe patients was significantly higher than those in the mild patients. These elevated D dimers, more than 1 milligram per ml, are therefore a marker of poor outcome in patients with COVID-19 infection. Even in the absence of severe symptoms, therefore, if you have very high raised D dimers, one has to be very careful because this can suggest increased thrombin generation, and therefore some people even advocate that such people should be admitted. Next, please. So if we look at it, what is the difference in the pathogenesis in the COVID-19 versus the earlier COVID infection that we had in 2003? There are a large number of similarities, but the major difference is, and which is proven on autopsy, is that in COVID-19, there is a much more multiple organ involvement than there is in the earlier SARS that was there. And this is largely because of thrombosis which occurs. Next, please. The second very important component is the microvascular thrombosis. And this is typically seen in small vessels. And what are the causes for this? An important cause is activation of mononuclear cells and neutrophils, which leads to more tissue damage, especially the capillary endothelium damage. Simultaneously, these release a large number of cytokines, which also disrupt the usual thromboprotective state of endothelial cells. Because of this, there are large thrombogenic potential of the small microvascularity that is present. And this leads to eventually microvascular thrombosis and multi-organ failure. Next, please. Now, as I told you, although we know this is released to cytokine release syndrome, there are about 80% of the patients who meet a typical diagnostic criteria for DIC. However, unlike the typical DIC, where fibrinolysis is more common, here most of them are in the hypercoagulable state. So much so, some patients even have gangrene. Therefore, this is a massive intravascular coagulation with more hypercoagulability present. In severe cases, there can also be acute respiratory distress syndrome, which means it is only delineated to lung. Next, please. So here in my next slide, I show you the pathogenesis of what happens in the lung. So as you can see, there is this is the blood capillary and this is the alveolar sac. Can you see my arrow? I'm not sure. So because of release of cytokines from monocytes, there is increased fibrin formation. Fibrin thrombi are formed. A lot of white fluid, which is also fibrin, and coagulation factors are present in the alveolus. And actually, because of this, people even think this increased fibrin may also be because of defective fibrinolytic mechanism. And therefore, some people even think that we can consider giving antifibrinolytics to these subjects. Next, please. Now we talk about bleeding. Do we get bleeding in COVID-19 infection? Very rare. Very rare because predominantly, as I told you, it's thrombotic. Yet, rarely you can get, and a lot of end-stage patients may have some bleeding due to consumption of platelets and coagulation factors. Next, please. So if we were to look at laboratory findings of coagulopathy in COVID-19, the first thing we have to notice is look at the D dimers. D dimers are elevated, as I told you, in a large percentage of patients of COVID-19. FDPs and D dimers have been found to be significantly higher in severe patients versus mild patients and survivors. Fibrinogen. We know fibrinogen is an acute phase reactant. So what do we expect? In acute phase, you expect it to be elevated. And it is in early course of the disease or the mild disease, it is elevated. However, later on, it reduces because there is a lot of consumptive coagulopathy that is occurring. So eventually, low fibrinogens are seen. Now, typically in a DIC, you would expect a prolonged PT and APTT predominantly because of fibrinolysis, which is very major component. However, in this, PT, APTT are only very mildly prolonged, if at all. In a lot of cases, people have actually found PT and APTT are shortened. And therefore, this is another suggestion, another finding that suggests that there may be a hypercoagulable state that is there. In a typical DIC, you expect marked thrombocytopenia. However, in this, platelet counts either remain normal or very mild thrombocytopenia may be seen. Next, please. So there is enough evidence to show, large studies are there, single center studies are there, which show that ISTH, that is the International Society for Thrombosis and Hemostasis score for DIC, was met in almost 70% of non-survivors, which is compatible with overt DIC. So just to let you know, ISTH score divides the DIC into overt DIC and non-overt DIC. So overt DIC is frank DIC, which was seen in 70% of survivors, non-survivors, vis-a-vis only about less than 1% seen in those who were survivors. The median time from admission to DIC development was 4 days. Next, please. Now, if we look at the various causes and mechanisms by which COVID-19 causes coagulation dysfunction, there are several factors. One is viral infection. Two is cytokine release syndrome. Three is immune-mediated damage to hematopoietic system. Four is ischemic hypoxia, reperfusion injury, drugs and other factors, and inappropriate use of blood products. Let's just briefly go into each of these. So viral infection. So one thing which was believed was initially direct viral toxicity. So we know that even though the previous SARS coronavirus and today's coronavirus both infect humans with ACE2, but the binding ability of today's coronavirus is 10 to 20 times more than it was present in 2003. And as I said, this virus leads to excessive activation of immune system, which damages the microvascular system and also inhibits the natural anticoagulant system present within the vessels. And therefore, DIC results in massive microthrombi in small vessels, leading to multi-organ dysfunction. Next, please. Cytokine release syndrome. The most important culprit is IL-6, but there are a huge number of other cytokines like IL-1 beta, IL-2, interferon gamma. All these cytokines also have a synergistic effect along with IL-6 to cause severe lung injury. Also, IL-6 stimulates the liver to synthesize more thrombopoietin and fibrinogen, etc. So actually, you might have more fibrinogen initially. Also, it upregulates the expression of VEGF, suggesting some kind of a vasculitis kind of a pathogenesis, which I will address later. So people have to still work and find out, is there a vasculitis or acquired VWF kind of a situation which affects Adams TS and also somehow affects the vessel microthrombosis. Next, please. Third is immune-mediated damage to hematopoietic system. Now, we know that coronavirus receptors include CD13, and hematopoietic stem cells, megakaryocytes, and platelets all express ICD13. So, the virus directly damages the megakaryocytes and platelets by binding to CD13, leading to reduced platelet count. And this can also cause activation of complement, leading to increased platelet destruction, a mechanism similar to that what we see sometimes in PNH. Complement mediated platelet destruction may be there. So we also know that lung is a major site from which mature megakaryocytes release the platelets. Lung damage happens, and therefore there is a decrease in platelet production. Similarly, there is increased platelet depletion because inflammatory damage causes the lung platelets to aggregate, and they cause aggregate and small thrombi are formed. And that's how immune-mediated damage also adds on to a thrombotic potential. Next, please. Now, we talked about ischemic hypoxia. So we know these patients have low PaO2 because there is a damage to the lung. There is also some degree of fibrosis that can happen to lung, leading to hypoxia. And this hypoxia reduces the anticoagulant potential of the endothelial cells. It increases the permeability and leukocyte adhesion, and the blood vessels, therefore, are dominated by pro-inflammatory properties. Because of this, there is an upregulation of tissue factor expression. This increased tissue factor expression leads to a procoagulant kind of an action, because of which thrombosis is triggered. Also, there is reduction in TFPI, that's the inhibitor of tissue pathway inhibitor, reduced antithrombin 3 and fructin C, which are natural anticoagulants. These damage the overall endogenous anticoagulant system, triggering it towards a thrombotic state. Next, please. Can I have the next slide, please? The previous one, please. So yeah. So there are a large number of antiviral drugs that that can be used, and some of these directly inhibit the hematopoietic system or induce liver injury, thereby reducing synthesis of coagulation factors. As you know, most coagulation factors are synthesized in liver. Therefore, anything that causes liver injury would lead to reducing the synthesis of coagulation factors. Here, I would point out even the natural anticoagulants like antithrombin 3 and protein C and S are also synthesized in liver. And therefore, liver damage can affect all these factors, triggering the system of thrombosis. Can I have the next slide, please? Now, a lot of such patients we use blood products. So as an immediate control measure, we use packed red cells because anemia may be there, and therefore we use packed red blood cells. And all these, if we use in a very short period of time, this will lead to dilution of other blood components, which can cause hypothermia, and all these can trigger the coagulation system. Next, please. So with so much of pathogenesis, everything pointing towards thrombosis, we have now moved on to treatment of only the infection to also a prophylaxis or a therapy for thrombosis. So the principles of management remain dynamic monitoring of the patients for the coagulopathy so that we have an early detection and can eventually prevent. prevention and treatment of venous thrombosis, stratified treatment of DIC, prevention of bleeding if at all, and supportive therapy and other treatments. Can I have the next slide, please? So in this regard, there have been several recommendations and guidelines which have emerged, the most common of which is the ISTH interim guideline on recognition and management of coagulopathy in COVID-19. Also, there has been ASH guidelines, and I will talk about some of these guidelines, just summary of these. Diagnosis, prevention, and treatment of thromboembolic complications as done by Netherlands group, and guidelines of Massachusetts General Hospital. Next, please. Can I have the next, please? Yeah. So I don't know how much of this is visible. So this is an ISTH interim guideline in recognition and management of coagulopathy in COVID-19. So, ISTH for DIC looks at 4 major parameters: the D dimers, the prothrombin time, the platelet count, and the fibrinogen. So if D dimers are very high, and if prothrombin time is mildly prolonged, and if platelet count is low and fibrinogen low, then we need to move towards giving the corrective factors that are required and also thromboprophylaxis. On the other hand, if D dimer is not very high and prothrombin is normal, then we need to look at imaging. And if imaging suggests there is a venous thrombosis, then we do prophylaxis. If it does not suggest thrombosis, then we go and monitor the case very closely. Next, please. Now, ASH has developed an algorithm for management of COVID-19 patients, because COVID-19 patients are put on thromboprophylaxis in US. So when they are put on thromboprophylaxis, you look at D dimer levels. And if you find that the D dimer levels are very high, you go ahead further. And if you find that there is thrombus which is occurring, or there is markedly increasing D dimer levels, then one needs to give treatment for therapeutic doses of anticoagulants. Low molecular weight heparin is what is suggested. On the other hand, if D dimers are not rising very high, then one can stay put with prophylaxis with low molecular weight heparin. Next, please. Massachusetts General Hospital guidelines, they say that we should always have baseline D dimer, PT, APTT, fibrinogen, ferritin, LDH, all these factors. Monitor D dimer daily or whenever the blood labs is being drawn. For patients in ICU, we must do all the coagulation tests of CBC, PT, APTT, and fibrinogen daily. Next, please. Management. For all patients who are admitted, we need to have standard prophylactic anticoagulation with low molecular weight heparin. And as you know, the typical things will follow for monitoring of LMWH. We will only follow it. Normally, it does not require monitoring. It only requires monitoring when their creatinine clearance is low, when there is an obese patient, or there is a history of heparin-induced thrombocytopenia. Next, please. Bleeding concerns are very few. And if bleeding does develop, you have to follow the similar principles of septic coagulopathy as per the ISTH guidelines with respect to the blood transfusions. Next, please. So personally, I like this very much, this chart. This is the guidelines from Netherlands, and they look at again D dimer levels less than 1 milligram per liter, between 1 to 2000 milligram per liter, and more than 2000 milligram per liter. So basically, if it is less than 1000 milligram per liter, you can have routine thromboprophylaxis, monitor. If it goes up, then you give therapeutic antithrombotics. And if it goes beyond 2000 milligram per liter, you need to give a therapeutic dose of anticoagulants. Next, please. So, with this, I would like to summarize that COVID-19 induced coagulopathy is actually manifest with elevated of fibrinogen, elevated D dimers, and very mildly elevated PT and APTT and platelet count reduction. So, in that sense, it is a little different from the usual DIC that we have. Increasing IL-6 levels are there. Coagulopathy appears to be having, it correlates well with the severity of the disease. Elevated D dimers have a poor prognosis and they have to be monitored. And rising D dimers is very dangerous, and we need to monitor D dimer levels regularly. Bleeding manifestations are rare. Next, please. So, as I told you, it is giving a DIC like picture, but it has much less thrombocytopenia and much less consumption of coagulation factor. And the major steps in management of COVID patients should include early diagnosis and follow-up of DIC. For this, we can apply the modified ISTH scores or any other score that we find comfortable with, and accordingly optimize the thromboprophylactic regimen in them. So future, what are the things that are still big question marks? One is the role of von Willebrand-like syndrome, and therefore there can be some studies because there is some vasculitis kind of picture which is there. So things like Adams TS and VWF multimers can be explored. Role of complement in pathogenesis of coagulopathy is another big question mark which can be explored. And one can also look into antifibrinolytic therapies as part of the antithrombotic therapies in this. Currently, we use only LMWH or heparins as per the patient need that is there. So with this, I would like to thank you very much for a patient here.
Thank you, madam. A must watch and a must listen seminar by everybody. And so this seminar link will be sent to all other doctors who are not there. And it's a must watch and a must listen. Let's now come back to a question answer session for approximately 15-20 minutes. And this will be a summary and basic points. I'm going to put down few situations and let's answer one by one. You want my start camera? Yes. So madam, I'll come back to very basic questions. Is 90% of the patients are at home.
Yes.
90% of the patients are at home.
Yes,
and they are not getting their profile done because they will be staying at home. Profile will be done only for those who are at admission.
Yes.
So I'm giving hypotheses one by one. Detection of silent hypoxia, that means on exertion or on talking, if their SpO2 level falls more than 4, which we classify them as silent hypoxia.
Yes.
Can that be a marker of, that means, can hypoxia precipitate hypercoagulation?
Yes. Hypoxia is known to precipitate hypercoagulation because hypoxia can lead to triggering of a number of interleukins, and it can lead to production of hypercoagulation. But we have to keep in mind that the hypoxia is not due to any pre-existing chronic obstructive airway or restrictive airway disease that is there.
So therefore, a patient who is being observed at home,
yes,
if he shows signs of hypoxia, the treating doctor, apart from discussing it with the hospital, till the hospital bed is available, should start him or her on oxygen and give him a stat dose of low molecular weight heparin, because testing reports will come later.
Yes, that is true.
That's situation number one. Situation number two is all patients who are diabetics, hypertensive, heart patients who are on a single antiplatelet drug. I'm talking about aspirin.
Yes.
And most people will be on a dual antiplatelet in the first year.
Yes.
But after that, most of them are on aspirin. And if these people develop COVID, even if they are at home, should we give them for the first 2 or 3 weeks a dual antiplatelet? I mean, it is not going to harm. It is safe. They have taken it in the past. Can it prevent a cascade in 10% of the cases? So what we tell them.
I'm not really very certain whether giving two antiplatelet drugs is really going to be so much helpful, because even though platelet component is there in this, that might be taken care of by aspirin. What one can explore other option is whether you would want to give any low molecular weight heparin prophylaxis or not. I'm really not
So,
sure whether two antiplatelets will work.
so there is a role of in high risk individuals who
Yes,
are being managed at home, and giving them a 2 weeks low molecular weight heparin makes sense.
makes sense.
I'm not talking about the
Yes,
evidence, I'm talking about makes
yes,
sense.
yes, yes, it
So
does.
my third situation is that the literature shows that 100% of the people who die
Yes,
have high D dimer.
yes,
And 50% of the people otherwise will have high D dimer.
yes,
So if 100% of the people are going to have high D dimer, and I know these people are critical, dying, and medically we know that the chances of survival are very low. Medically we know that. Now these are the people who are getting renal failure because of microthrombi. I normally call them as you have a heart attack, brain attack, lung attack, penile
yes,
attack, you have a leg attack. This is a whole body attack.
yes, yes, it
This is
is.
a whole body attack.
It
I mean,
is. It is.
every artery and vein may get thrombosed.
Yes, yes,
And in pulmonary embolism, in DVT, we give prolonged fibrinolysis.
yes,
Means we used to give them streptokinase 1 lakh every hour for 72 hours
yes.
to have not only fibrinolysis for a small time, but continuing the antifibrinolytic activity. Do you feel that, and again, not talking about evidence, do you feel
Yes.
that with a shared decision with the doctor and the patient, if you feel that you are losing the patient, it is justifiable with a shared decision to give them prolonged fibrinolytic therapy in a situation which is going out of hand and you have evidence of very high fibrinogen and a very high D-dimer level?
So, as I said, there is people are exploring this option,
Okay.
especially looking at the autopsy findings where we find these fibrin deposition over there. A lot of fibrin gets deposited in the alveoli of the lungs, and leading to eventually fibrosis also happens, because eventually. So there may be a justification in giving it a trial, but as of now, it is not recommended in any of the guidelines. But people are exploring and looking very carefully at this kind of a option for such patients.
Another
I
thing
don't
is
think
that,
there are.
agree,
I don't
there
think
are,
there are any studies on this as
so
of now.
there is a condition called silent hypoxia
Yes.
where the oxygen levels are very low, but the
Yes.
brain is active. That means there is
Yes.
no cellular hypoxia in the brain.
Yes.
So, what can explain that? Is it that we have a microthrombi in the lung vessel? Along with that, there is a angiogenesis, blood flow continues. There is a cellular hypoxia, but the blood flow is normal and CO2 doesn't get retained. What can be the reason? Because again, it has to be linked
So
with the
again,
microthrombi.
yes. So again, it could be there can be small pulmonary microthrombi which are there, which may be causing some kind of a pulmonary arterial hypertension kind of a situation, which may be leading to reduced oxygen saturation in the lung. But about VEGF and causing new vascular genesis, it can be a conjuncture. But as of now, it's not been demonstrated anywhere in any of the autopsies. It has not as yet come. So we cannot really say on that.
So I presume and I hypothesize, because when there is a new disease, the best is to hypothesize.
Yes.
My hypothesis, and which I am following it with my patients. And my
Yes.
hypothesis is whatever you do, when you have a silent hypoxia, it cannot be explained without a small microthrombi, as on today.
Yes,
Because there is no,
absolutely. Absolutely. If there
if
is
they,
slight hypoxia, there is some microthrombi definitely present.
okay, if microthrombi are present, then at that particular juncture, along with oxygen, low molecular weight is
Yes.
justified. So
Yes, it is
therefore,
justified.
I will take it as a recommendation of this conference that consider, because it is not
Yes.
a recommendation.
No,
So
it's not.
consider giving a low molecular weight heparin the
Yes.
time you detect a patient having
Yes.
silent hypoxia along with
Yes.
oxygen, and
Yes.
then start looking for the bed in the hospital, because
Yes.
in today's crisis, bed may not be available so easily, and but you still will get with this couple of hours, maybe a day extra to find for a bed
Yes.
with that.
Yes.
Another thing,
Especially if
madam,
D-dimer is high. Especially if D-dimers are high. Should get it
yes,
done.
yes, D-dimers, you should get it immediately. Small
Yes.
machines are available,
Yes.
and
Yes.
D-dimers can be done. Spot D-dimer tests are available, even if it is not quantitative. At
Yes.
least qualitative tests can be available. Quantitative
Yes.
tests can be done later with that.
Yes. Yes.
And another thing which I want to say is in the last couple of days, we are seeing a large number of patients, families together. And that means 9 people in the family getting fever, 7 people, 6 people, 5 people. And this is a post lockdown effect. And
Yes.
a post lockdown effect is that they started going home from the home. One person who is the earner, he started going to the shop, public dealing, and invariably, no social distancing maintained. He comes back, opens out the mask, doesn't use it at home, sits with the family, small room,
Yes.
crowded, and he passes on the infections to everybody.
Yes.
So
Yes.
we are getting a large number of cases. I might have talked to at least 11 people, and if I calculate, at least 55 people has got fever in the last one day who got infection in the family, and all of them are going to be managed at home. So therefore, my message to all my viewers who are watching this program, the doctors and the non-doctors who are watching, that make sure that don't ignore your disease even if you are at home. Talk to your doctors, buy a SpO2 monitor, and SpO2 monitor, if it is showing low oxygen, it may be too late. Before that, walk little bit or talk. Walking and
Yes.
talking, if SpO2 falls by more than 4, don't wait for 92 or 90 to occur. If your oxygen level is 98, if it becomes 94 on talking, on walking, talk to your doctor. That's the time to start low molecular weight heparin, specifically if you have an underlying hypercoagulable state, which is known to occur in patients who are high risk, hypertension, heart failure, immunological disorders, immune suppression. In such cases, you may be able to prevent certain deaths with that. And how common is thromboinflammation in India? Have you, I mean, Medanta is a COVID hospital group.
Yes, it is. I think by the time this thrombotic thing came up, we don't have COVID patients as of now, so many. So I think we have to look at our data and see how common it is.
So do you feel
I
that
can't
the
say.
large number of people who are dying in Europe
Yes.
and in US, they are almost, Europe is triple the Indian
Yes.
number
Yes.
and
Yes.
US is double the Indian number.
Yes.
And if you see, all the European deaths are hyperimmune inflammatory disease. They
Yes.
are a hyperimmune response. So maybe in India we are not getting a hyperimmune response, and
Yes.
maybe and in India, if we just manage hypoxia with low molecular weight heparin, we should be able to reduce the mortality.
I think we should be able to reduce mortality if we do that. And there are several things by which we can say that maybe India, and I can just say maybe because we really don't know exact numbers, maybe we have a less severe uh, disease than there is in the West. Maybe the percentage is lesser than West. We can't really say till our entire data comes through. But it is possible that the immunization by BCG to the Indian population may be bringing up the immunity to some effect, and maybe that's one of the reasons why we may not be having as much very severe cases as in the West. We are having, of course, but maybe not as much as it is in the West.
So for my viewers, I want to simplify it. We have two types of immunity, like you have a dacoits or a thieves coming to your house. Before the police comes, you try with your own personal security. And that personal security, you give a call, they come immediately because they are being hired by you, they are your personal property. And this is called inmate immunity. And when you call a police take its own time. Either they will come with a gun called IgM, or they will come without a gun, which is IgG. And when your inmate immunity, your own personal security, you arrange, When in India you have large number of diseases, every now and then you end up into a disease. Maybe your personal security may be higher. Maybe in COVID infection, our innate immunity is slightly stronger than the internal innate immunity of the US or of the Europe. And that may be the reason we are getting, most of us are getting milder infections. And whenever we have a reduced innate immunity, there the mortality rates are higher. That's one of the hypotheses. Today we are, when it comes to COVID, we only talk about hypothesized things. What comes
Yes.
out and whatever who is the truth, whosoever brings the truth will get a Nobel Prize. So till that, we continue our hypothesis and with a prayer that all our viewers stay healthy, keep your family healthy, keep your community healthy, keep your state healthy, keep your nation healthy. On all of your behalf, I thank Dr. Renu Saxena for giving this beautiful presentation. The talk will be available on our website for years together. And I hope after seeing this program, at least some deaths will be prevented. Thank you, madam.
Thank you very much.